I might just start off with some introductions. So Stephen, if you wanted to go first, and just so maybe a brief introduction, then just introduce yourself and go from there.
Yeah, no problem. My name is Stephen Patterson. I research blood flow restriction, and I've been doing so for the last probably 10 years or so, longer actually, probably 13, 14 years. And I did my PhD in blood flow restriction way back, started about 2006, 2007. So we've been looking at it for a long period of time. I work out of St Mary's University in London. I mainly work on the strength conditioning masters there. So we work with a lot of people who are working in elite sport and sort of consult and discuss blood flow restriction training and its applications regularly to different groups.
Awesome. Thank you very much, Stephen. And Barry, nice to meet you. And if you want to introduce yourself.
Yeah, nice to meet you too, Joseph. My name is Barry Sigrist. I'm a graduate sports therapist by sort of degree, which is a bit of an ambiguous term. Sort of cross the physio, rehab, and due to previous background, sort of sports science wise, go into a bit more of like sort of the S&C stuff as well. So quite a sort of a broad remit, backgrounds in football, Formula One and motorsports. And just generally at the moment, just consulting as a rehab specialist in London and private practice generally. In terms of blood flow restriction, mine is purely as a practitioner. I've got no academic background in studying it like Stephen has. But yeah, so my experience of it is purely application in a clinical setting, really, and in football, really.
Awesome. And I might jump in. And so my name is Joseph Marcus. Background is exercise and sports science and exercise physiology. And I did my Doctor of Physiotherapy degree, and in my thesis project was BFR training back in 2014. And after 2014, I've actively been developing AirBands, which is a wireless BFR device, and joined the team at Vold in 2019. So that's sort of my background with, So we might just move over to starting some questions now. The first question is, what is the rationale for blood flow restriction training in athletic populations? So what do you perceive to be the major benefits for an athlete to use BFR training? Is it rehab, load management, or hypertrophy, or even strength? So maybe Stephen, if you wanted to jump in and sort of discuss that briefly, and then Barry, feel free to jump in as well, and just go from there.
Yeah. Look, from my perspective, the biggest area for athletes is injury rehab. I think the tool fits quite nicely for individuals who are load compromised. They're through a situation, they've had an injury, and they just can't lift those heavier loads, which we normally would use in order to gain sort of adaptations and strength, hypertrophy, and so on. And to me, that's where the big sort of opportunity is in those early stages, especially those early stages of rehabilitation, where we can potentially, in some cases, accelerate rehab, in other cases, just either maintain or regain muscle mass and strength, which then allows us to then go back to other conventional methods and spend more time maybe focusing on stopping and re-injury occurring and so on. I think there's still, obviously, when you become healthy and you have healthy athletes, if you'd asked me this question probably maybe 7-8 years ago, I would have said, no, it's only rehab. The more you speak to people, the more work we do, the more I do see it being used by healthy athletes. I just think it depends on what it is they're trying to do. So load management, certainly one. Periods of deloading, the ability to use less load, so less mechanical stress on the body, is certainly an advantage. But it has to be taken with caution in that we know we're not getting any greater gains with blood flow restriction than we do with heavy training. So it's weighing up that balance of the coach deciding when is the right opportunity to put this in place. And you see it, if you see people using it and they're using it as finishers and they're using it at the end of exercises. And actually, Is it doing any real benefit? Probably not. If you're using it from a management of load perspective, then of course there's a different argument. And we spoke to quite a number of teams and people who are currently using it in that manner. So there's certainly scope there with that.
Well, one question which I've sort of come up fairly often has been coaches and individuals asking about integration of BFR into high load training. Could you talk any sort of from your experience briefly about that? So just basically, so adding BFR to sort of 70% 1RM or whatnot.
Time and time again, there have been a couple of studies that have come out and tried to investigate that. I actually did one of these studies as part of my PhD, and we actually stopped the study halfway through on that arm of the study, because what happens whenever you use a high load, essentially, because of the pressure that you normally get from lifting a heavy load anyway, and then you apply the cuff on top of that, actually you just can't get the repetitions completed. So you end up saying that the adaptations aren't of the same standard, because there's too much pressure applied in the system to allow you to get the repetitions done. There have been a few studies that have looked at it. One or two have maybe looked at potential benefits, but most of them have suggested that there's no potential benefit there. And I don't, anytime I've used it or seen it that way, I don't see anything positive happening. It's mainly due to that, lack of repetitions being allowed to happen.
Would anything around sort of the analgesic effect of potential analgesic effect of BFR be useful for higher load training, or that's some sort of rationale that you could see a utility for? So say someone has anterior knee pain or whatnot, and they can't perform a loaded front squat because of knee pain. Would you think, say, some BFR training pre the squats would help sort of manage any sort of, or that's?
Yeah, there's certainly scope for that. And that's something that we're really interested in. We've just finished a paper that's just come out a month or two ago, looking at optimizing that sort of methodology and what sort of exercise has that greatest analgesic effect. So for example, we looked at low load training on its own, we looked at heavy load training, then we looked at blood flow restriction at both 40 and 80% of limb occlusive pressure. And we basically found that the blood flow restriction was better than heavy load and low load. And actually the blood flow restriction training actually had that analgesic effect for up to 24 hours after the exercise bout, in comparison to the other two groups. And now that's in a healthy population. We've done other work in clinical groups as well, which has shown the similar things, and it lasts for that period of time. So I think that there is certainly an argument around, and certainly it's an area that we are really interested in, around the idea of, those little niggles and pain that athletes have just from everyday training, from games and so on. There's certainly a lot of scope there. And I know in America, especially in the NBA and basketball, it's used like that quite a lot. They do a lot of training, blood flow restriction work after the game. A lot of times because they have to travel, they've got long flights and so on, and coach journeys in the States. And they would use it there for reductions of pain, plus also then getting your a stimulus in for an adaptation in a very short period of time after a game. And some of them use it pre-game also.
I think I read a study looking at a lunge exercise, and I think they did a counter movement jump afterwards, and had like an increased flight time of like 4.9% or something like that, like maybe 15 minutes afterwards. So that was interesting in terms of like a conjunction of BFR with like a warm up kind of protocol. Would you think that's sort of a promising?
Yeah, I think so. I've seen the study that you've talked about. I haven't fully read it, but I have read the abstract. And then there's another study that came out by Jamie Burr's group in Canada, and they did a very similar thing. They looked at ischemia, and then they either did electrical stimulation or just basic walking. And what they found was that if you increase the metabolic stimulus of the warm-up, you get an even greater improvement in performance. Now, we know that already, that some of those high intensity warm-ups are quite useful. It's the balancing act of when too much is too much, and it's too much metabolic load, and then all of a sudden you fatigue someone before they perform, and that causes the negative side of things. So I think there is benefit, but we probably need to do the work to find out what's the optimization of that protocol.
I think that's probably been a little bit of an issue with the uptake of sort of the application of BFR, is the fact that the methodology or how to apply it is relatively unknown or a bit more ambiguous in terms of it does seem very promising for a number of different sort of applications, but just the how you apply it, or because saying doing high intensity resistance training every day is probably not a great idea. And so in doing BFR training twice a day, every day, probably isn't a great idea, but figuring out what dose is sort of most effective, I imagine, or what application.
Yeah, look, I think there's plenty of information there. I think like one of the we did a study, it's about 5 or 6 years ago, with Chris Brandner, who's an Australian guy working out in Qatar now. And me and Chris did just a questionnaire study of practitioners. One of the things we were wary of is, well, what are people doing? And we asked that question, and we had about 140, 150 responses from people who had heard of blood flow restriction and were using it. But when you read some of the things they were doing, some of the protocols they were using, some of the reasons why they were doing things, none of it, not all of it, but some of it didn't make sense to us, you know, from reading the literature and what we're doing. And I totally get that. You know, people are doing things, they try things, they see what works and so on. But at some stages, in the concern we had was some of it was starting to look a bit dangerous. And, you know, my concern was obviously from a safety perspective, making sure that was going to be the case. So I think there's an education thing there. You know, from my own perspective, I get bored of reading things, you know, and there's only so much you can read and keep up to date with. At the minute, blood flow, I would say there's a paper or two of blood flow restriction coming out every week. It's hard to keep up with what's going on and who's doing what. So it becomes one of those situations where, as a practitioner, if you find something that works very quickly, you stick with it, and you're not worried about it, irrespective of someone else has proved that this one's better and so on. So I think there's a little bit of an educational aspect of it, as well as just I think there is a bit of people originally think blood flow restriction would be a little bit gimmicky. You know, you're restricting flow, what's this really happening, all these sorts of things. And there's, you know, the evidence is pretty clear. There's plenty out there, but, you know, people have to have strong evidence for really to jump on the bandwagon of doing things, and sometimes just have to experience it themselves. And equipment plays a big role. There's, you know, now there's a lot of more equipment on the market than there was. If I look back when I first started, we couldn't get anything. You know, it was so that, you know, all that's changed, and you find that more companies involved, and all of a sudden there's more knowledge, there's more information coming out, and people are now starting to get into it a lot more.
No, I think, definitely would be very interesting in terms of the practitioner side, and sort of, I think there is probably some sort of status quo kind of bias, I imagine, in terms of what people are already doing, and then sort of changing that will take a sort of either upskilling and sort of feeling more confident with something. I think it's basically exposure, I imagine. That's probably the role of education, particularly around BFR training. I imagine some sort of like, getting people comfortable, because on the face of it, it does seem, very promising. But I think people not knowing sort of exactly, or feeling confident with applying it, sort of, or when to apply it. But I think that probably moves on to our next question. I might direct it towards you, Barry. Sort of the role of blood flow restriction training in non-injured athlete populations. So from just your experiences, what do you think? I think we've probably touched on that quite a little bit just then as well. But would you think sort of, how would you answer that? Would you say load management? I guess probably would be the first thing that comes to my mind.
In non-injured?
Yeah.
I mean, load management being the primary, I mean, I pretty much exactly what Stephen said, really. The performing athlete with low compromised joints, it's an incredibly powerful tool to help manage them, to keep them on a pitch, to keep them rolling them out on a Saturday. It's a super important and a really useful tool for that. Certainly, anecdotally, I look at some of the knees that we've managed, and we managed with it, and allowed people to get game minutes, 45 minutes, 60 minutes, and blood flow restriction helped us achieve that in a number of ways, really. So, with using it in their activation, So if they had their individual activation work, it was definitely something that was utilised, is utilised. I guess in a similar way. I mean, we started doing that sort of a few years ago, and I think in terms of pain modulation, we didn't have a great deal of information on its effects then. But like you said, you find something that works and stick with it. And for those like arthrogenic muscle inhibition, those AMI knees and stuff, it was super useful to get quads going, to almost prep the muscle to protect the knee, to protect the tendon, to protect the fat pad, all those sort of irritable anterior knee pain structures. It was really useful for, but keeping them going, like you said, in terms of load management for somebody that hasn't got that kind of sort of requirement, if you like, I think it just goes back to those sort of intense periods of match play, really, doesn't it, in competition, where you might have a short turnaround, where you still might need to find something that can give you that stimulus on a muscular sense, but without that cost at the joint and those passive structures. And there's not many other tools really that we have that we can get that kind of trade-off, that also have that the system that you're stressing and you're getting the benefits from also has quite a quick turnaround compared to, sort of more traditional methods and the systems that stresses. So in terms of in athletic populations, I think it has a great use, and historically, in a lot of my backgrounds with those pain and rehab sort of settings, but there is definitely a crossover into the non-injured and the people without that injury history now. I think historically hypertrophy is a bit of a dirty word in performance, I've always found. If you talk to practitioners about putting on mass, it can be an interesting conversation, because often like I said, it's a bit of a dirty word. So I think blood flow restriction had that stigma around it, and that's why it was used in a rehab setting for a long time, bulking up quads and stuff like that. And I wonder if people we've just been a bit narrow-minded as a profession, as a sector, and focusing on that as its use, and not really understanding actually the evolution of the evidence base and all these other benefits that it has.
I think you mentioned something really interesting, was the sort of as a tool. So I think definitely understanding BFR is like not the, I think the pendulum sometimes really swings. I think like some people would be hesitant with using a new tool, and as they get more knowledgeable about it, they might try to use it too often, almost. I think understanding that BFR is a tool, and then when it's useful, it can be extremely useful. But then obviously strength training is the gold standard for strength and conditioning. And if they can engage in high load strength training, then obviously that's the best thing they can do. But then there'll be times where an athlete can't engage in high load strength training for a number of reasons. I think that's when BFR, because there is no good secondary option. I think you could have low load to failure or whatnot, but like just thinking about it in terms of like, what are the second best options when you can't do high load training, not including BFR. Like I can't think of many other sort of modalities so I think and also like in football, an example, like how much S&C exercise, I imagine that some teams would be quite hesitant in doing a lot of strength and conditioning, and mostly on the pitch. So I think I can see one utility for BFR training would be if they wanted to do their S&C on the pitch and make it as sport specific as possible, and sort of like use lower loads and have it more, it's like sort of keep it all on the pitch. So I know a lot of soccer teams don't like.
Yeah, it just depends on the management really, and the people, that leadership group who's driving the strategy. I'd probably say the more sort of UK based teams in that sense would have a bias towards S&C, and really wanting to periodise that when you can, when the fixture list allows it, which is obviously a really tricky thing in football. But obviously in the UK there's a huge influence from abroad now, and they've got a different sort of way of doing things quite often, and it does tend to be a little bit more, in my experience, lower load, more volume, and less time in a gym with weights as such. Yeah, so it really depends on philosophy, which varies so widely. But I get just going back to something else, which I think this is really useful for in a rehab setting. That it's the psychological element of blood flow restriction is quite interesting, because I think it can really give an athlete a sense of progress quite early, because they're working to a level which, in terms of the way it feels, really early in their process, when a lot of their conversations are often around injury, limitations and stuff like that. All of a sudden they're doing something quite early that's going to progress them, and they're getting that feeling of hard work when historically they might not have. They would have expected to be sat on their backside for quite a while, just getting treatment and stuff. So there's a psychological component with the right kind of athlete, which this can really feed into and be really powerful, I think.
Yeah, no, having I think like having done in Australia with a professional working with a special sports team, the segregation of sort of rehab athletes and then the squad, there is that element of like separation, and then probably if they are have sort of the varying levels of weight bearing, or they can't engage in sort of high intensity exercise, definitely this will be some sort of psychological wellness aspect. But I think I did skim over a paper which I think was like maybe sprint intervals or whatnot, and it was comparing mood states with BFR and sprint high intensity interval training. I'm fairly certain I read something briefly regarding that. I think it came out probably like either this year or last year. But I think that's super interesting in terms of like the psychology of an injured athlete, and allowing them to sort of exercise at a more perceived sort of higher exertion level than they typically would sort of physically when they're loading wise. But a question that sort of would be brought up fairly often, and I might direct it towards Stephen, sort of periodization of blood flow restriction training. I know like the protocols are fairly consistent in terms of how to apply BFR, but in terms of periodization, so could you speak a little bit towards that?
So there's no real literature out there about periodization of blood flow restriction exercise itself. We've got a paper out at the minute which is sort of an overview of how it's used, and a load of people all over the world have contributed to it. And if you look at the programming guidelines, they're pretty straightforward. And it is one of those things about it. It's a pretty straightforward tool. You're talking the usual 75 repetitions, 30, 15, 15, and 15. Now, you can play about with repetitions. There's no problem with that. That seems to be the correct volume. If you do any more than that, it doesn't seem to give you any added benefit. You can mix it up and go to failure, although we probably suggest you don't do that too often because of potential negative response that you could get with people. But so from a point of view of periodization to BFR, it is pretty consistent in that regard. You could go up and down the limb occlusive pressures, and change the pressure slightly depending on the individual. I just think, from my own perspective, I don't believe we should be using it long enough that you really need to periodize it. It's a tool that is implemented for a short period of time, early rehab, deload, microdosing, those types of things, and then you move back into your normal conventional work. So you periodize the blood flow restriction into your overall bigger plan, and because you've got a reason why you want to use it, and that's why it's then been implemented. I think with regards to how it's, if you're changing up how it's used, I think on one aspect, it's a very simple tool. We talk about education, but it is simple. Once you know how to put a cuff on, once you know how to make people do repetitions, it's not a tricky thing to get your head around. It's all the other things you have to think about that go with it.
Would you, in terms of occlusive pressures, would you say kind of discomfort, and particularly if someone either is quite novice to just weight training in general, I imagine sort of an 80% restrictive pressure or 50% restrictive pressure can be fairly uncomfortable. Would you use sort of discomfort and scale occlusive pressures based upon that, or would you just keep it sort of an arbitrary pressure and just maybe don't get them to do as many reps?
Yeah, like for me, you want to try and measure limb occlusive pressure nearly every time. I think once you start using arbitrary pressure, if you look at the literature, that's where we got into issues. I even look back to my first PhD study. I got really lucky, and I hold my hands up, and I made one of this. I got away with something that actually was a stupid thing at the time. We picked the pressure from the literature, but looking back, they had a cuff that was completely different size to what we were using, and they used it in the arms, and we used it in the legs. And luckily, it was the right. It was a low, so it worked as a lower pressure for us overall. But realistically, that could have been. If I had went too high pressure there and made a mistake, I probably wouldn't have been continuing on with it because I would have said it didn't work. And actually, pressures in the literature anywhere between 80 to 300 millimeters of mercury as arbitrary pressure set. By standardizing the limb occlusive pressure, just gives us a bit more guidance of what we're doing. So I think with using different pressure, I just think that's the sort of optimal way to go with it. So we just know exactly what we're applying. But I think if you have a situation where you have someone who isn't able to get, say, that 75 reps game and isn't getting close, then you bring down either the load, you bring down the pressure. It depends what way you want to go about it. I think one of the things I would caution against is a little bit what Barry said there. Athletes like this because it hurts, right? And they're kind of used to that with a lot of their training. So that they've got that mindset, they've got that mentality. But we find that works with, doesn't matter what age. We've had 80, 90-year-old individuals do this and it hurts, but they like it because they come back for more. What we found with our work and around the pain side was the more discomfort you have in the muscle, the greater the analgesic effect. So that's why we think that 80% is better or working more, because actually you've less oxygen and so on, and it's driving those sensors to sort of it feels the pain in more detail. So I think there is an aspect of, I'm obviously the first time you use it with someone, you don't want to make them have so much pain and never come back, of course. But the pain in the muscle isn't the problem because it subsides. Obviously, it's pain in joints and other things. That's the bit obviously we don't want to happen.
No, awesome. I think I answered that really nicely. We might move on to the next question. So this is something that I'm probably become very, very interested in, is the role of blood flow restriction training in predominantly a skill-based movement. So a golf swing, baseball pitching, shooting a basketball. I was just going to put it out there. Do you see a role of blood flow restriction training in more skill-based movements? My sort of thinking was loading that skill-based movement with, say, a weighted bat and changing the fundamentals of the movement isn't probably the best way to improve the skill, but having more of a metabolic load as opposed to a mechanical load. But that's just, I'm really keen to hear you guys' thoughts. We might go with Steve, if I want to kick off.
So I'm a little bit torn on it. Obviously, I've not seen much or done much specifically to look at it. The one concern I would have would be that obviously, because even though it's not a high mechanical load, the metabolic load will still potentially change the movement pattern, depending on how long you are you're occluded for, how intense the work is and so on. And obviously, that could be negative if it's obviously changing the movement pattern of the skill itself. So there's some concern around that. Now, that's not to say that there aren't times that we want to train under some elements of fatigue. And obviously blood flow restriction could be that tool that allows you to get to fatigue quickly to allow you to do that. But I don't know if it would then be training with the cuff on while doing the movement. It might be you create local fatigue in the muscle, therefore to then train the movement. But a lot of skill sports potentially don't need to be trained under those conditions. If you think of the golf swing, you've got plenty of time before you walk to your next ball. You've got, if you're a baseballer, and you've got plenty of time before you hit your next shot. All these things, so they don't necessarily need that metabolic load to improve that performance. So I don't know is probably the best answer I can give. Parts of me suggest no, but I said I couldn't be sure.
It's a very specific period to be training for, isn't it? To put that kind of metabolic load in, then test skill. you'd probably be doing your skill training or getting much more out of it doing it under in a normal training environment, wouldn't you? I suppose if you had it on, the only thing it might give you a bit of a proprioceptive device, wouldn't it? But like you said, but then that's going to potentially change things, and you're not going to have that on when you're playing anyway. So what's the I'm not too sure about myself.
Yeah, no, I thought it was quite an interesting. The thought was quite interesting, but I think the points you raised would be definitely very valid in terms of like a golfer does have plenty of time to restore their energy. I think it wouldn't be so much of a fatigue set, but yeah, I think that's would be a curiosity. I'd like to see something in terms of like that sort of further, even from a sort of, yeah, I'd like to see that sort of further explored. I think that's probably, I imagine as BFR training gets sort of more validated in terms of strength and hypertrophy are quite solid, but then I imagine now people are branching out in terms of different elements of how to apply, I guess. Yeah. So I did
see a paper a while ago. I don't know when, it wasn't published that long ago, but it wasn't a skill-based sort per se, but they did put cuffs on individuals when they were training in soccer and football during the training sessions themselves. Now, the part that worries me is that we end up getting, you're talking earlier on about that swinging of that, that balance. And it worries me that what happens is people go, oh, well, it works here, let's do it for everything. And actually, you start to have to think about the logic of what's going on, and how long are they doing it for, and why. And yes, did they get in performance improvements? Yes, they suggest that they did, but the control group isn't doing. So they're not sort of balanced studies in some aspects. I think you will see stuff, but I think some of the times, I always say this to our students, just sometimes because stuff hasn't been done doesn't mean it needs to be done. There's a reason why some people don't do certain studies is because sometimes it's not worth it and it's not going to add anything. We already know before we apply it. That's not to say you don't ever test hypothesis and try and drive it out, but I think sometimes we just have to think logically about what is it we're trying to do here, and then take a step back and go, actually, is that going to cause that adaptation we think it is?
Yeah, I think that'd be a very good adage, just to have back towards minds in terms of, yeah, you might have a sort of a feeling towards something working or not working even before you sort of go down that route. We'll move on to the next question. So what's the most, it probably lends itself to sort of flowing into this next question quite easily. So what's the most interesting application of blood flow restriction training you've seen so far, and what would you like to see in the future? So Barry, where do you want to kick this off?
I mean, I'm pretty boring, old-fashioned, I suppose. I mean, the physiological sort of underpinning of the strength and hypertrophy stuff I find super interesting. I think initially because of my ignorance in that area when I was first introduced to it, to blood flow restriction training, I was sort of quite a bit resistant to it. So very much traditional loading was the background and stuff, but as in sort of delving a bit deeper into its mechanisms and stuff. And the more we're finding out, I mean, that stuff still I find pretty bloody exciting. And a rehab perspective, definitely anything to do with the proximal effects on the cuff is a really useful thing to start to understand, to see if there is benefits, and if there's there is a crossover effect on that. Especially those times, like Stephen talked about, when early stages of injury, when even before we can load that side, what if we occlude the other side? What if we get to work on that using this method? Is there a crossover effect when we might just do our active movements on our affected side? So yeah, anything to do with crossover effects and proximal effects, or effects proximal to the cuff, are the stuff that I really want to see a lot more of, really. And I've seen one or two things about it, and early indications sort of suggest that there's something to it, but very, it's certainly not something you can really confidently 100% say yes, look, this is happening. As far as I'm aware, Steve might be able to tell me a bit more on that, but yeah, that's what excites me at the moment on it.
Yeah, I think with the crossover effects, it really depends on the exercise it's chosen. So what we tend to see is if you use an exercise which has the, so say for example, you do a squat or a leg press. Well, then as the quads and the hamstrings start to fatigue, the glutes take over. And so there is an adaptation that occurs above the cuff itself. Certainly there's potential neural transfer from a strength perspective. We know that in normal resistance training. So there clearly is some small cross transfer to, say, the other limb, but there certainly isn't any hypertrophy cross our sort of effect of upstream of the cuff, because if we look at even just some of the basic sort of physiology studies on, in order for muscle to grow, the muscles have to be recruited. So the fibers have to be recruited. And actually, if the other limb's not doing anything, it's not being recruited, therefore it's not going to increase in size. And all the sort of original hypothesis around circulating hormones and all those ideas, they were diminished with Stuart Phillips' lab, and then they showed, because if it was that easy, we'd do one exercise and everything would grow. If it circulate what was going around, and it'd be great. But obviously that's where there's issue. Now, I say that, and I'm pretty confident that that's the way it works. But there is a study that's come out of the States looking at the shoulder, and it's done a lot of sort of external rotations and so on. Now, my argument always is, if you're doing any sort of movement like that, there's nothing happening upstream of the cuff which would then adapt. But they're showing, there's no fatigue happening downstream of the cuff, which then is what's happening. And to me, what you're getting, say, for example, the 75 good repetitions of external rotation. So maybe that's what's happening there. But there is a study that's just come out from a group in the States which have shown some potential upstream adaptations. But again, something I need to look into more. But I need to have a look and see whether the exercises chosen have meant that's why that happens and so on.
I can recall sort of two studies, like looking at, one was both restriction applied to the thighs, and one study was, I think, did bicep curls, I believe, so unrestricted bicep curls, and I think they had an improvement in muscle size and strength unrestricted. And the other study was 2014, I think it was Cook, and I think it was like occlusion training 3 weeks with like semi-professional rugby players, and I think that they did 70% 1RM, 5x5 squat, bench, and pull-ups, and the restrictions only applied to the upper thighs, but in the BFR group, bench press strength went up pretty significantly. So I'm not too sure. Like it's. Could you speak about sort of like, what would you think? Is it some component of some sort of? Because I know the originally they were talking about referring to like sort of positive sort of hormonal changes, but those changes would be, if they're just very acute, like too acute to actually cause anything. Because obviously with the endogenous hormones like that, you would assume chronic increases would lead to sort of strength and hypertrophy, but acute increases probably would not. But could you sort of would you say the mechanisms behind that in terms of like unrestricted limbs still training, but sort of with restriction being sort of further away than so the arms and legs?
Yeah, like I think there's an element of the first study you mentioned that's sort of by a guy called Madarame, I think it was 2010 or something like that, a Japanese group. There's an argument that in an untrained population, they're nearly getting to fatigue anyway with 75 repetitions at a low load. I'm not saying that's the case, so that maybe explain some of the reasons. I know Stuart Warmington out of Deakin in Australia, they tried to replicate that study. And what they couldn't demonstrate the increase in hypertrophy, but they did demonstrate a neural cross transfer effect. So the strength I can understand, the hypertrophy I can't. I think is there a potential benefit? And the other Cook study, there's a few things that I don't want to say, criticize people's work. I don't mean that, but first of all, the heavy loading. There's no other studies which are showing the heavy loading works. So that's straight away. I think there's a bit of an issue around blinding, and the idea that if you've got the cuff on and one group know they've got the cuff on, does it lead to a bit more intensity when you train the upper body? There's a potential there, and I'm not saying that's the reason. I just, when you look at the research, you have to go, if you weigh it up on balance, most of the stuff shows that doesn't happen, and there's a couple of studies which show it does, and you have to, at the minute, I'm on the other side of the fence until there's more comes out the other way to say this is definitely that way.
No, I think that's a very well balanced answer. I think like what would be super useful would be getting into sort of more specific applications. So like the two things that I sort of have flagged has been, I know there was basically it's pretty famous now. I imagine the stages of BFR training. So like, but in terms of like how to implement specifically BFR training into a athlete's rehab journey, what that would look like, and then how to what would, and then the use of BFR training to maintain cardiovascular fitness. So that would be the two sort of questions that I would have sort of to round this out. So the first one would be, so what do you see BFR training applications for an athlete's sort of rehab protocol? And I know it's sort of like a passive use has been sort of hypothesized, then sort of progressing to aerobic use or just walking, and then progressing to resistance training. But yeah, so how for strength coaches out there, what would you say that landscape looks like? Happy to jump. Anyone jump in?
I mean, it's certainly in a rehab setting. It's just a really difficult question to answer, really, because there's so many variables and so many, conditions-wise, the requirements are so different. I think, like Stephen said earlier, is the fact that you can get it in really early makes it useful in so many settings. If it's whatever low compromised joint, like soft tissue structure, even if you know your loading, your athlete, you can start to use it and take advantage of it in a really early setting. I would say depending on the I think you sort of go back and ask yourself some questions. So things like what's their weight bearing status? What access do you have to cardio with this athlete? So are you, there's some a fair amount of evidence, although really on sort of more D conditions, about just utilising it in walking protocols. So if they are full weight bearing, can you utilise those kind of walking protocols with blood flow restriction early? But then obviously if they're above that anyway, you can probably, the chances are you're going to be able to start to work them on a bike, aren't you? Then in terms of, I wrote down a couple of questions actually, the ones that sort of sprung to mind in that. So how long are they going to be out for? Is their metabolic conditioning going to be an issue within this injury? Is it, like with the amount of time they're going to be out, are you really going to need to stay on top of it? So in terms of prioritizing whether you would require to do that in that setting, to work on it aerobically, and therefore like how much of a pressing issue is that? But initially, usually it's going to be around structural adaptation early, isn't it? So what's the structure? Where is it an active or is it a passive structure? What direction does the structure take stress? If it's a hamstring injury, for instance, and it's very much a sagittal plane muscle, are we going to use it on all our work, or are we going to use it just in that sort of anything that's sort of sagittal plane, hip or knee, AP type directions, loading, and then therefore, so we're able to get access to that work tissue very specifically at a low load, but get all those extra benefits of, blood flow restrictions without the tissue stress and strain. But then perhaps going a bit more unrestricted for the other exercises, which, if you're injuring your hamstring, but this is very crude, and obviously it's stressed in that direction, but all that frontal plane movement where you can get frontal plane loading relatively early, getting the band off, then attacking your hamstring in more of a normal traditional type loading in the frontal plane. So in short, it just really depends, doesn't it? I mean, it's a very long answer, a long-winded answer to that sort of age-old physio and S&C type line of it. It just depends.
I really agree with Barry in that, and I know it comes back to that, it depends, but you know, the model that Jeremy put forward, you know, that passive walking and the resistance exercise one, it is a really nice idea, and it's taken the literature that, you know, that's been done sort of and looked at it. But there's a reason why if we look at sort of the research, nobody's done it that way when it comes to the research then. You know, nobody's actually said, let's take someone passively and then we'll move them into endurance and then we'll do it with the resistance exercise. Because, you know, even if I look back, we've finished an ACL study last year in the NHS. You know, after 2.5 weeks, 3 weeks, we were loading them with resistance exercise. And there was no need to load those guys any earlier from an ACL perspective. We're not getting them back into function any quicker, you know, in that regard. You know, there's a process, a time restraint with regards to an ACL. So that's not the aim. The aim isn't to try and recover quicker. The aim is to get that structure back and then allow you to spend more time on other factors. I think it depends if you've got an athlete. Obviously, there might be a, you know, conditioning side. So the endurance aspect might come into play a little bit more because obviously you've got that, you know, you don't want to decondition too much, and this may, you know, give you an opportunity to do that. And also I think it depends on what you're also using. We've, one of my PhD students, Paul Head, he's doing a PhD with BFR and neuromuscular electrical stimulation. And again, looking at situations where that might sort of come into play too. And we think that's probably a better use rather than passive alone. There's a, you know, a few studies on passive, but actually there's some questions over them and they haven't been repeated in 10, 15 years. So there's things there, and the couple that have done it haven't really found the same benefits. You know, we've got some work out of the neuromuscular stim work which show it's effective. It should be. It's doing exactly what we do with the, you know, normal resistance exercise, except we're, you know, applying that stimulation. But like everything, there's a time and a place. So for certain people that may apply, others it may not. It all becomes into what the injury is, what the timing is, you know, how much swelling have they got. All these things are going to play an impact in deciding what you're going to use and when. And so even though blood flow restriction is an umbrella term, there's 3 or 4 ways it can be used. So, you know, it's not just one tool, there's 3 or 4 tools within it. And then you go, well, actually, which one applies to this current setting for me to get the adaptation or whatever it is I'm looking to drive?
Yeah, I think in terms of your reservations with the passive use, I think that's probably, yeah, it's extremely well founded. I think, yeah, that the repeatability of those studies, and also the fact that there just may not be, there's no mechanical element to it. It's all metabolic, and whether that's enough to. But there was interesting studies in animal studies in terms of hind limb restriction and and preventing sort of unloading injuries. But that was like application pressures were way higher and application times are way longer as well. But I think so. Yes, the 2000 Takarada study was like, yeah, 2 applications a day, 25 minutes, and that probably seems to be what everyone sort of refers back to. But yeah, I think. It was, I think, I can't remember recall, I think someone tried to replicate that, I believe, like not too long ago, and it didn't seem to be, I think they even added in isometric exercises to it as well, and it seems to be any added benefit.
There was a couple of studies, there was another Japanese group, Kabata, did a couple of studies when they did show a benefit during mobilization and so on. But there was a more recent one, Iverson out of Norwegian.
Yeah, that was it, yeah.
They didn't see any benefit of it in that one. There's a nice study that came out of Brazil in intensive care patients, and they did it. But what they did have was they were given passive movement by the ICU nurse. So whether or not that, and they potentially did see some offsetting in atrophy, and whether or not the movement with the cuffs on rather than just the alone, you know, we don't know. We actually have a study where we did a similar study in intensive care patients. But we didn't actually, we ended up sort of stopping the study earlier because of recruitment issues more than anything, and we don't think it was positively showing much influence. So I think our recruitment was, they were almost too sick actually to be recruited in some aspects. So, but you know, if it was me, I think, you know, we've done some case study work, we've done some work with some Premier League teams, and we've seen some really, you know, really good results from basically offsetting atrophy almost completely with neuromuscular stim and BFR in those early stages. But obviously, still has to be a movement element of that, you know what I mean? So that's a process, and then the next stage then begins, and so on.
So mapping that out. So say for using an ACL as a condition, injury, surgery date, then you say 2.5 weeks until surgeon clearance or whenever that might be, and then implementing strength and conditioning, but then BFR training in that early stage, sort of either electrical stimulation in the first couple of weeks, and then combining that with sort of regular sort of strength rehab program for an ACL. And then at what point would you say you pivot away from the BFR training? Would it be when their strength levels are pre-injury levels, or when their limb symmetries are sort of same, or would you?
I think you can go in there pre-op first and foremost, can't you? You can get some really like you said about the offsetting the atrophy and some of the strength deficits, getting there early. Providing the joint allows, then getting there before the operation is definitely an option, and depending obviously on the time that you get given between injury and the operation time. In my sort of experience, it will be like Stephen said earlier, again, it was just until you can get them to load, it's going to, like in a traditional sense, it's going to be your primary method. But then going forward, when you are looking to really stage your return, and you start to really look at load managing the joint itself, giving it that stress and that real all those sort of gains from the traditional loading, and this can help support that. I would say like there's a place for it to slot in parts of your week where you might, and that might change, I guess, in the morning when you get the athlete back from yesterday, and then all of a sudden we can't, you're not really sticking to the plan, but there's enough there that you can give them a little bit. It's a flexible tool to fit into those gaps going further, and then obviously depending on the joint, the situation with the joint, for me, how you manage that going forward, it could be with you for a long time. It could be with the player back into performance, but that will depend on the type of injury and what you're dealing with.
I also think there's a big area which hasn't really been looked at from a research perspective, but I think there is a big gap, and I think there's definitely an element with athletes, but a massive element with regards to sort of just general public and operations and so on. But prehab to me is a really big area, in the fact that we can, even with a lot of these injuries, for surgeries, people can still move, but actually we can do that with a reduced pain and actually get some loading in. There's an argument even with some of the athletes, Premier League football now, they'll get surgery in the next day or two, but there's an argument of saying, well, actually, should you wait and actually do a 2 or 3 week high frequency prehab? And because for example, what we know happens after an ACL is that we lose a lot of satellite cell content afterwards, which is then what causes a lot of scarring and so on. And actually we know from some studies with high frequency BFR that we can actually get a really big increase in muscle mass and strength early on in a sort of 2 to 3 week block. And that's maintained for 10, 15, 20 days post. Plus, so is the upregulation of those satellite cells. So actually, if we do that before, we could be coming out the other end in a lot more positive and beneficial way, which actually then leads to, you have better maintenance of muscle mass, and then actually even greater improvements down the line. Now, it's all speculative. It's all just taking one study and trying to put it together. But I think there's a couple of studies I know that are currently happening in prehab, but I think it's a really big area that is sort of underutilized, especially if we think of here, just in the UK and the NHS, people are waiting for operations for a very long time. And actually we could be doing things with them and you might even find some people don't need those operations all of a sudden as they get stronger and they get muscle mass back. But I think there are sort of potential uses there which aren't currently being explored.
I think that's everything that was said is extremely useful information, just to map out sort of like what I think you were mentioning, Stephen, is like getting one study and slotting it in and sort of speculating how that journey may look. But I think just to close it out a little bit would be like how, when, and why. Sort of, I think that's probably what I sort of always lean back to, is like how, when, and why. It's like why are we doing this modality? Like when and why are we doing it? I think that's probably 3 really good questions, and sort of having an understanding to what you're trying to gain. But I think that and then having that really maps out your decision making in terms of like, oh, when do I apply something, and why am I doing it, and what does it look like? So I think that's particularly useful. But I think that was really interesting. The precondition was super interesting. I think that's probably, I remember reading one paper regarding ACLs in terms of vascularization, and that which seemed very interesting at the time when I saw that, and I was like, oh wow, that's cool. But I haven't read too much else about it.
I think they did one when it was like eight sessions, wasn't it? As little as 8 sessions before the surgery date, and how that carried on for like, you know, just 8 sessions worth of blood flow restrictions, and how that sort of perfusion and some of a significant sort of maintenance of muscle mass and strength going in for like 4 or 5 weeks. I think it was 4 weeks actually. I think post, I can't remember the paper off the top of my head, but it's definitely got legs, I think, in that area, and around sort of osteochondral defects in the ankles and stuff. You know, you think of those chronically unstable ankles and suffering from that same sort of joint-driven issues. I don't think there's anything on that sort of area, but definitely, again, options around that, I'd say.
Cool. And the last question I had was, why do you think, first of all, do you think, in terms of the blood flow restriction training, sort of uptake in terms of, because you mentioned that since being aware of BFR training for almost 15 years now, Stevie, personally, and I'm Barry, I was for years and years. I sort of, do you imagine sort of BFR training is prominent in sort of in the S&C landscape now, or just the rehab landscape in general? Or do you think sort of what's maybe slow, or just regarding sort of feelings regarding BFR training?
I think like from certainly there has been certainly a bigger uptake in the last couple of years. There's been no doubt about it. I've noticed it really big time, and a lot of that's come from the States. There's I did a talk at a conference last year at the States, and there was about 1,000 people in the room, just all on BFR. It was a physical therapy conference, and we wouldn't get anything like that anywhere else. And they, now the worry I have is I think they might be going the other way of that pendulum. I think they might be getting a bit too excited with it and sort of using it too much. But as long as there's some sort of, clear thoughts around it, if you even just look at the research, I reckon if you go on to sort of search what some of the pre-registered studies, they're actually through the roof. Some of the biggest labs in the United States now are doing blood flow restriction research. That's the sort of big thing. And there's been surgeon buy-in over there, and obviously then that's then bought into the argument of, well, then the surgeons then filter it down, and they're happy for their patients to then have treatments. And obviously with it's sort of driven out of the teams. The teams have all bought into it, all the NFL, NBA, college teams and so on, and they all have private medical insurers, and then they go, well, why don't we use it with the healthy populations? And it just spirals down. So that's where, for me, I've seen a really big uptick. Even just in S&C alone, there's been a lot of people who we now know are using it and seeing it. There's definitely more knowledge out there, as far as I can see anyway.
Yeah, I'd say from my perspective, in the S&C space, if people aren't actively using it, they definitely know about it, and they're open to the idea that it could be useful. That's from the last couple of years. That's what I've noticed quite significantly to be the case. And I think, definitely in terms of the mounting body of literature has definitely aided that. And I think Dwight Howard had a ESPN segment just specifically on BFR training, which was like, pretty unprecedented for another sort of training modality. I can't even think of another training modality which has got that much attention previously, which was, so I think, in America it seems to be, quite very, very prominent that I've seen. I think maybe something to do with like their insurance model, or maybe or the fact that it could slot in very nicely to that. But I also think BFR training is probably, of the modalities I can think of, is a very sort of physical kind of technique where even if you don't particularly know what the methodology or science behind it, you can sort of intuitively notice how it works. I imagine that patient buy-in and clinician buy-in would be very straightforward, and then plus when you combine that with the literature, it seems to be quite a salient kind of modality. But we might wrap it up. That's an hour thereabouts. If there's any sort of closing remarks from you guys, feel free to jump in.
I'm just on the rehab setting on that. I think a lot of it's just about education in the physio sort of landscape in the UK, certainly. I think blood flow restriction is very much seen as a S&C and sports science application. And you know, when you've got the dual qualified physio sports therapists who have a sports science background, they can really see where it fits in and how you can utilize it. But generally speaking, it's just not taught widely in depth here, I don't think. Certainly in my experience, and certainly in CPD and stuff like that, you know, like it's touched upon, but you don't really get any meat or understanding or pointed in the direction of where to go to really understand this a little bit more. It'll be, you know, a couple of slides of, by the way, you can use blood flow restriction for this. So I think, like, certainly in the UK, and in the physio sort of side of it, it's just the level of knowledge, and therefore its application in rehab. Perhaps it doesn't then really get to the individual, certainly in a non-athletic population, until they start working with, if they're lucky enough to start working with an S&C, in which case they're paying out their own pocket anyway. So I think we're sort of a bit behind on that sense, and like, I think generally speaking in the UK, in the MSK rehabilitation setting in the private sector and NHS, we're not quite as pro exercise as we really could be. Let some people making the right noises and we're going the right way, but we're still not quite where, like, the Australians are, unfortunately. But hopefully we'll get there, and it will start to get a bit more prevalent, and the understanding will come. I just wanted to throw that in there because I missed the opportunity earlier.
No, you're okay. Probably more a reflection of my abilities as a host or a panel host, as opposed to awesome. Stephen, any further to add?
No, like I said, I'm pretty much in agreement. I think we've done a study in the NHS. We're working with another NHS trust at the minute, but you know, you get sporadic. I get sporadic emails from different NHS trusts and so on, and people who are interested in doing it. But actually, it's hard for them to get things off the ground with regards to, you know, being able to centrally buy equipment and all the other things that go with it, because actually you almost need the whole NHS to be accepting of it before then they'll actually then bid for stuff and all that sort of. So, and that's something I don't know much about, you know, I'm holding my hands up there, but I think it's an easier one in with, you know, you find it that the physios who work more in sport and then also then transfer into that health market as well, they're fine, they do it, and they, you know, they do understand it, and they see a merit in it. You know, I certainly think there is a big opportunity there with regards to clinical populations, and the fact that it can be used very quickly. You've only got a short period of time to see someone and so on. So it gives you a lot of bang for your buck, you know, pretty quickly and so on. Obviously, the only thing you have to be careful of is once you start working with those populations, there's more health morbidities that are going on. And actually then we have to start making sure screening is in place and correct. And that's where people need to have the understanding and knowledge to know why they're doing it and making sure they're applying it in the right situations.
Yeah, I think that's a very useful point, would be, making sure that when using it with more athletic populations, probably could get away with a lot more, because they're much more robust, I imagine. But if you're applying in more clinical populations, that's making sure they're adequately screened and just for major risk factors, I would say, and then understanding the differences between sort of feedback, I guess, from the individual in terms of what they're saying, they're feeling while the cuff's on and whatnot, would be also pretty useful for the clinician implementing it. But I think that from my point of view, I think that was a really great try, but like, yeah, apologies for like, if there's any incongruencies with the questioning. We're pretty new to this, so. But honestly, thank you very much for you guys for your time, because I know it's pretty late there where you guys are, so that's really appreciated, and thank you for jumping on board. And
thanks very much.
Yeah,
no,
thanks.
thank you guys. No, thank you guys. Was there anything to add, Erin, or can we wrap up now?
No, that was really good. Thanks, guys.
Cool.
I'll let you know. I will kind of edit all of these in separate videos because you each submitted some presentations. And then I'll release them this Friday is when I'm looking to do it, and to promote it over our social media and then in the newsletter that's going out next Wednesday. We've got just over 4,500 people subscribed to the series at the moment, so it's a really concentrated group of practitioners worldwide, which is awesome. And then our social media following collectively has about 10,000 people following it as well across the mail channels. And then I'll also try and cut up a little bit of this for the AirBands channel and use it there. But thank you very much for your time, for jumping on.
No problem.
Thank you very much.
Thank you.
Thanks, guys.
See you later. Bye.